All right. Good morning, folks, and welcome to Friday Chalk Talk. My name is Martin, and I'm a palliative medicine doc working at St. Luke's here in Milwaukee, and I'll be your moderator for the day. Today we have Peter Stussy, and he's a clinical pharmacy specialist in oncology and a longtime friend of our palliative care team here at St. Luke's. He also works here at Luke's with us with Advocate Aurora, and he's going to be talking with us today about the combative language that we find in cancer. Today's format is going to be a little different from the past. It's just going to be an open discussion throughout. So feel free to unmute and jump in at any time. And as a reminder, these episodes are being recorded, and we have a repository of them stored on YouTube for those folks who can't be here live. So with that, thank you guys all for being here. I hope you enjoyed today's talk. And Peter, I will hand it off to you.
Thanks a lot, Martin. As Martin mentioned, today's format will be a little different. I stumbled across this particular topic multiple times over the last several years and recently came across an editorial in the ASCO journal, the Journal of Clinical Oncology, that truly made me ask Martin if it was okay if we did a chalk talk on this and that I'd be willing to help lead it, but I am not an expert. And I don't believe the literature gives any definitive way to approach this topic either. So I wanted it to truly be a discussion amongst all of us today to discuss how you have approached it with your patients in the past, some pitfalls, some things that have gone well concerning this particular topic. And then I thought I really liked this particular editorial had kind of a top 10 recommendations that this writer wrote, and I wanted to share that at the end. As Martin said, please feel free to interrupt at any time. I'll be trying to prompt with questions to open up the discussion throughout. So with that, I wanted to show that our organization also uses combative language straight out. This is me trying to look really tough because, no one fights alone. This is a shirt that is actually given out to our caregivers throughout our Wisconsin system, our Wisconsin side of the system. The Aurora Cancer Care is still a branded kind of group for our Wisconsin clinics here. And so a lot of our Wisconsin clinic caregivers, well, they're team members now in this organization, I should say, were given these shirts, including myself. So that fights alone, the fight against cancer, considering it a fight where it's the patient versus the cancer, is kind of one of the major topics that we'll discuss today. So I thought I'd share that our organization is also using this in the public vernacular. I'm sure we're all very well aware of this being used quite a bit. Some say that this truly began with President Richard Nixon in 1971 declaring the war on cancer, and that kind of started everything off here. Other examples that I saw in the literature and what they are meant to purvey to patients, including cancer cells being enemy invaders and using various weapons of war, such as surgery, radiation, drugs, immunotherapy against these cancers. And then the fights and the battles are generally related to, the couple of cycles of treatment or of radiation treatment or something in between the scans. How did this fight go? Did the cancer shrink? Did it grow? What happened? What happened during that battle? And then beating cancer. How do you beat cancer? Well, sometimes in the literature it's been noted as remission, or sometimes it's also cured. So I wanted to open it up to the group. What other kinds of language of combativeness and war have you all heard used in your practice?
Peter, if you don't mind, I was gonna jump in here. I see this used really often with our veterans. In fact, they use it, I think, oftentimes in themselves. I have, and I don't want to generalize this to all veterans. They're as individual as every other patient, but I feel like I hear them sometimes talk about how changing a code status to a DNR or enrolling in hospice or setting other limits is surrendering. I hear that word used a lot, and I'm not sure if that's a mindset that goes back to their training. And sometimes I'll even hear them talk about fighting until the very end. And I struggle with that piece with veterans in particular, because I'm trying to do two things. I mean, I'm trying to assume that I don't understand everything and be empathic, and maybe that is a really important part of their goal, to fight, and helping them reframe things about what they want to fight for, which may in the end still be the same thing. But that is something that I have seen a fair amount.
I hear Christian Sinclair, University of Kansas. I hear a lot of people just talking about winning and losing, and instantly, even if they don't say I lost because the cancer is winning, just the feelings or the pervasiveness or the things that are unsaid is that, well, if you didn't beat it, you lost. And therefore, if you lost, then you're a loser and you could have tried harder, or you somehow could have willed it. So for me, it's the things that are said, but it's also what they imply and what is not said that is harder to get at sometimes, because those feed a lot of different emotions for the patient, for the caregiver, for the clinical team. And it's hard to talk about the implied feelings when they aren't said out loud.
Great discussion. I thank you very much for everyone for chiming in. Also, please feel free to read some of the chat responses. I appreciate those coming in as well. Not giving up the battle, the giving up coming up quite a bit, coming out of the battle language. Dr. Sinclair mentioning that, there's winners and losers in a war, in a battle, in a fight. So a patient feeling as though they lost. That's a real danger of these sorts of metaphors being used. And I think, and in the literature, it plays out too, where most of what I was reading was also talking about some of the concerns with using some of this particular language. Just want to keep going, because some of the points that are being mentioned as well are also things that I'm mentioning. Shrink this down right now. So here is just one Google search, just some of the stuff that's popped up. On one Google search, when you put in, memes these days, memes being so huge in our online culture these days, that can come in. I just wanted to give a small example. The one that I think the one that concerned me and scared me, honestly, the most was the one with the angry wolf. Mom loses battle with cancer, should have fought harder. And that to me is the patient fighting the cancer here. I think that can be so destructive, unfortunately, to our patients in quite a few ways. So I just wanted to share a couple of these. I don't know if anyone else has seen any that are ones that they've seen a lot as well. But all right, trying to move on here. Okay. So in the literature, again, I'm going off of the references that I've found, as Dr. Sinclair had mentioned, why should this be avoided in circumstances? What's the danger here? Wars have winners and losers. Winners are the survivors, and the losers are dead, are those that the cancer wins. I don't believe that at all, personally. It's definitely hard language for these, for in those sorts of circumstances. And then what is hospice then? As mentioned before, Dr. Barzilek mentioned, hospice is then surrender. You're surrendering. I mean, I don't believe that at all either. And I don't think we should have our patients believing that in any way, shape, or form. And using these metaphors, puts feelings of disempowerment, and guilt and fatalism in our patients. When used, patients perceive treatment to be more difficult. When they've studied this and the use of this sort of language, they've found that if you use different language when communicating with patients, it actually changes the patient's perception of their treatment. They have a harder time with treatment if you are saying that the chemotherapy and radiation and surgery are the weapons that you're using. The patients actually tend to have a stronger response to the adverse effects of those particular treatments. And it undermines some of the passive preventative strategies. Why would you quit smoking when you can just use chemo as a weapon to fight the lung cancer? So these are just some of the impacts that can have on patients. So again, I wanted to throw it out to the group. Any comments on why you think we should possibly avoid these sorts of metaphors? And also, where might they be useful for certain patients?
So oftentimes when patients do find the fight metaphor to be helpful, I think reframing that fight metaphor towards, I'm not asking you to stop fighting. It's really about reframing what it is that you're fighting for. As you approach the limits of what modern medicine can offer you, people can still understand that fight metaphor, just focusing it on something new that is really important to them.
Hi, this is Carrie, also from Aurora at St. Luke's, and I completely agree, both with Martin there, and then Mel made a couple of comments in the chat. I think the fighting language used to bother me a lot more because because of the things that you're saying, Peter, it frustrated me to focus on the part that losing comes along with the fighting language. But now I do really try to meet patients more where they're at, and like Martin and Mel said, explore the various aspects of different things that they might be fighting for, and then trying to bring that back to what are the things that we can control versus not control, and how to put that all together to try to see if they can view things from a different perspective, but also not to force their own perspective out of them if that's what they lean to.
Peter, this is Steve Rommelfanger. I'm kind of struggling with this topic because I too hate the battle imagery and the violence, but I also recognize that I've myself been blessed so far not to have to deal with serious illness on a personal level, and I don't know how much having this kind of language helps a patient rationalize what they're going through or gives them some sort of framework for understanding the reality. I am curious though, and I don't think we have anyone on the audience currently, but I'm wondering how when you're going through training in residency or training to become an oncologist, do you get indoctrinated with this language, or I'm just curious how an oncologist would perceive this discussion.
Well, based off of my discussions in the past with the oncologists I have worked with, I think many of them, most especially the older ones, grew up with the war on cancer. And I mean, that was the language, that was the approach that everyone used. So it is definitely something that was a part of their training and their practice for so long, that they continue to use it at times. I think there is a push in the national organizations. If you look at ASCO, for example, they are definitely trying to push away from framing the cancer treatment in this in this particular manner. And part of that is, such as the editorial I wrote that prompted this discussion. And there's definitely quite a lot of other literature out there talking about, and I'm trying to summarize just a small portion of it here, but there's quite a bit more about the dangers and concerns and the impacts on patients from utilizing this types of language.
Well, and this is Leanne Lau, Hospice and Palliative Care Fellow at Medical College of Wisconsin. I guess the only thing that I wonder, and I don't know the literature well enough to speak authoritatively in any way, but we, from our perspective here on the hospice and palliative care end, are looking at a select group of patients. Does this language impact the people who do well with their cancer treatment in a positive way for them to feel like this is something where they do get to be a winner? And so I think, there's a consideration there for the fact that we are seeing a selected group of people who go through this language. And the only other thing that I was thinking, as someone was saying, that the idea that it's a violent war and everything, I also can say that I've been blessed to not have to go through cancer on my own, but from the people that I know well who have, I think they do feel like it's a violent thing happening in their body. They do feel like it's an ugly, horrible thing. And so I think the idea of ignoring those thoughts from a patient's perspective may also not, we can't try to sell cancer as a cute little puppy dog. It is an ugly thing. So I think trying to avoid that part of it may not be effective either. So I think this is really tough.
Christian, I saw you had your hand up. Did you want to say something?
Here. Yeah, just the historical war on cancer, for those who may not be aware, Richard Nixon signed legislation that they branded the war on cancer in 1971, so in the middle of towards the end of the Vietnam War. So even the public's first introduction to when we started talking about cancer openly in the 70s and getting into the 80s was all framed in public forums as a war on cancer. And I mean, even the war on cancer, it was likened to the Manhattan Project, which is, atomic bombs, all this scientific engineering, and we're going to put all this towards defeating an enemy. That's how it was really introduced to the public in the 70s. And so now, 50 years later, we're still dealing with that.
And in the chat, there was a comment that, and it was also mentioned previously, that it really is not beyond just cancer, but medicine in general often brings in this metaphorical language. So thanks everyone for their comments. I don't want to, we could probably discuss this for hours on end for sure, but I want to make sure I keep with the time frame as best I can. So is there a place? I think we already mentioned where there are definitely some areas where there probably is a place, and reframing the fight might be a great way to approach it. It's a little easier for some patients to understand using these metaphors than trying to use other more scientific language at certain times. And it's pretty straightforward and easy to understand for sure. That's definitely been mentioned. But, again, there are some dangers, and it's been mentioned in multiple articles that I read that, what does that do for the prognosis discussion? How, that surrender if, the prognosis is poor, I don't want to surrender, quality of life then if they want to continue therapies and those toxicities of those possible therapies. You talk about the weapons that you're using, but then you have a tough time then talking about all the issues that could come with it. So I wanted to, before we just open up the discussion again, so this particular editorial was actually written by an intern. He was not, but his background was language, was English creative writing. So he had a top 10 most important things. And I just wanted to share those with the group today. Maybe there's something good in here that you could take from it, but I thought these were interesting, if not very just well thought out. Listen to your patients, not as important or interesting as they are. Individualize it to fit the patient, as many of you have already said, just as you individualize your treatment plan. And this was written to oncologists, by the way. Think carefully before using war metaphors. Becomes difficult to bring up palliative care in the midst of total war. Likewise, patients may feel pressured to live up to the image of a heroic warrior who exhibits enough grace under pressure to make a Hemingway protagonist blush. Once again, this is a creative writing guy. Be prepared when patients and their families use combative terminology. He's a fighter, they might say. Without dismissing this expression of faith in the patient's mettle, consider reframing the fight, as everyone has already mentioned. There are many goals someone can work towards, such as freedom from pain or more time at home with family. So many of these has already been mentioned in this discussion today. Patients and families may think of palliative care as surrendering, as we've all mentioned before. Start by defining palliative care, comfort care, and hospice. They are not synonyms, and misperceptions are common. Again, this is written to oncologists. Hopefully they read this. And try introducing palliative care early, both the concept and the team. If you wait until the end, you take the advance out of advanced care planning. I'm sure everyone listening today has run into this particular difficulty in advanced care planning with their patients. I guarantee it. Be careful discussing cancer in terms of winning and losing. She beat cancer or lost the battle. Patients may feel agency and pride when treatment is going well, but when it isn't, they can feel blamed. And blaming the patient and I like this next one, because avoid saying patients failed chemo. Patients didn't fail chemo. Chemo failed them. I actually was talking to a patient just several weeks ago now, after I had read this and everything, and they were moving on to their next treatment for metastatic cancer. And they used this line, and I said, no, the chemo failed you. And they're like, I hadn't thought of that. They really felt like it was on them to do it. And it's like, no, it's the treatments that are supposed to do their job. So in this particular circumstance, it worked. Simplicity is a virtue for any jargon. Act like a good dictionary. Be precise and direct. Sometimes metaphors help convey an idea, but other times they obscure the point. Some patients will find it a relief to have frank discussions about cancer, suffering, death, and dying, using that exact language. And then I love this last one. Never use the words nuclear option, ever. All right, so I'll open the discussion. If we have a couple more minutes, I'm not sure. Maybe we should be done at this point, Martin. But I'll leave that up to you. But that was the end of my presentation today.
Wonderful. Well, thank you, Peter. We've got about 5 or 10 more minutes that we can use for discussion, if there is any. So we open the floor up to anybody.
I can just mention, please feel free, open up the chat. There's a lot of great comments coming through. Using the old Hail Mary pass is probably not a good one to use either.
Wonderful. Right. Well, if that's it for the day, then thank you, Peter, very much for leading the discussion. And thank you, everybody, for participating today. And we'll see you all next Friday, and have a wonderful weekend.
Thanks, Peter.
Great talk, Peter. Thank you.